welcome everybody. Welcome to everybody here in the room, as well as our colleagues online. Thanks for joining us today. We are really privileged today to hear from one of our newly appointed professors here in the School of Public Health. As you know, these Dean's Lectures provide us the opportunity to hear of the great work that our newly appointed and promoted professors and our senior scientists are doing in the school. And we get to hear today from Pamela Collins. And Pamela, as I think everybody is well aware, just started in July of last year. I can tell you personally, I was just thrilled when she agreed to move all the way from Washington State here to Baltimore and to join the School of Public Health and become the chair of our Department of Mental Health, the only department of mental health in the country. Although I keep saying that, and I know Danny Fallon will be starting a Department of Population Mental Health at Emory in no time. But anyway, it's a great department, and we were just so fortunate to have Pamela agree to come and take the department to the next level. Pamela is truly a superstar in the field of global mental health. There's no question about it. As a psychiatrist and a mixed methods researcher, she brings a deep and diverse toolkit to her work, and she has spent decades helping vulnerable communities, both here at home and around the world. She has an extensive track record, not only in research, but in education, training, capacity building, as well as policy and science policy. She is she's been here a little less than a year, as we said, and I can tell you that she's busy putting all these skills that she has to work as she charts a bold future for our Department of Mental Health. And as Pamela herself has said, this is a time of great possibility. We are currently living through an extraordinary period of mental health awareness, triggered in part by suffering experienced through the pandemic. And now we have a chance to seize this moment to drive real change. And we know that change is desperately needed. There are nearly 1 billion people living worldwide with a mental or a behavioral health condition. Suicide rates are on the rise, including among the young. While millions suffer from substance use disorders, only a fraction receive the treatment they need. These are deep and very complex problems, but we know that public health approaches can provide powerful solutions. And Pamela has shown this in her own career time and time again. She has been a leader in studying the design and delivery of mental health interventions for marginalized people in a variety of different cultural contexts. During her time at the University of Washington and her years at the National Institute of Mental Health, she spearheaded research initiatives to extend mental health services to places around the globe where they're most needed, often by finding ways of bringing in non-specialists into the care. Her research and practice has a broad reach, ranging from studying the intersections of HIV and mental illness in the US to reducing suicide in indigenous Arctic communities. She even served as an advisor to Oprah Winfrey and Prince Harry in their Apple TV mental health docuseries, The Me You Can't See. So, I mean, you know you've made it when you're asked to consult with Oprah. So kudos to that. But truly, this kind of work is a powerful example of how Pamela is bringing the truth about mental health to a very broad audience. Over the last few years, she has increasingly focused on adolescent and youth mental health in the global context. This includes everything from studying how we can best collect mental health information through smartphones to training Kenyan community health volunteers to help young people experiencing symptoms of depression and anxiety. Pamela is bold and she is creative, both in her own research and in her leadership of the department. She is helping to push us in ambitious new directions as we work to meet the world's evolving mental health crises. Her colleagues will tell you that in her time here, Pamela has shown a meaningful commitment to building community. She is deeply inclusive and has worked to strengthen the department's already very strong social bonds and its sense of collective purpose. And I can say that extends beyond the Department of Mental Health to the school more broadly. She has just dove right in to working with the other chairs across the departments at the school, and has become a very critically important member of the leadership team here at the school. She's a forward thinker who is always brainstorming new ways to connect with potential stakeholders outside of the school, whether it's organizational partners, the media, or mental health advocates. These efforts are helping to bridge the gap between research and practice, and they help position our people even more strongly as the go-to experts. Pamela operates on the world stage, and she is working to ensure that the entire department and the school, but specifically the department, is a global resource for mental health, population mental health expertise. Pamela, thank you so much for all you continue to do for the school, and for all that you continue to do to help people around the world live healthier and happier lives. So Pamela, the floor is yours.
Thank you so much, Ellen. It's a real pleasure to be here today, and I'm going to move through this presentation because I also want us to have some time to talk at the end. So let me advance the slides. I'll start with a little bit of an orientation. In preparing this talk, I realized that 2024 marks my 30th anniversary working in global mental health. I started as a psychiatry resident, and in browsing through old papers, came across a statement that my mentor Ezra Susser and I wrote 25 years ago, which remains true today, that the challenge of the present epoch is to build effective mental health care systems using the local resources that are, in fact, available. I would say that this remains a challenge, and over the years, we have found additional challenges to meet as well. So why does mental health as a field need to stay on the global public health agenda? More than 1 billion people around the world live with mental and substance use disorders. More than 700,000 people die by suicide annually. Many of you have heard these statistics. The majority of people with severe and common mental health conditions do not receive adequate services. This is a map of the global burden of disease due to depression, and this is measured in disability-adjusted life years. Darker red means that depression actually is a greater contributor to loss of healthy life on this slide, and darker blue represents lesser contribution. So what do you notice? These conditions occur everywhere, but there's considerable variation. Deep orange and reds coincide with areas of conflict in some cases, but sometimes not. And you might be surprised where you see the areas of deep blue, and you might wonder, is that real? Is that a measurement issue? What is that? And those are questions that we as a field ask too. But overall, a complex set of drivers influence the prevalence of these conditions. And the complexity reminds us that our field is actually about more than disease. The field of global mental health is undergoing a kind of revolution. As commissioners for the Lancet Commission of Global Mental Health and Sustainable Development, we celebrated the inclusion of mental health in the Sustainable Development Goals. The health goal is to ensure healthy lives and promote well-being at all ages. So this presents an opportunity to reframe mental health and mental disorder within this broader conceptualization. And to accomplish this by reducing the burden of disease through prevention and treatment, while also identifying approaches to promote population mental health and well-being around the world. So we proposed 4 pillars on which this reframing can rest. And these are that mental health is a global public good that's relevant to sustainable development in all countries. Mental health problems exist along a continuum from mild, time-limited distress to chronic, severely disabling conditions. because this more accurately reflects the complexity of people's real-life experiences. Personal mental health reflects the interaction of social and environmental influences with genetic, neurodevelopmental, and psychological processes. And our field has to continue to deepen our exploration of how all of these factors come together in ways that protect and sustain mental health or increase the likeliness of mental illness. And finally, mental health is a fundamental human right that requires a rights-based approach to protect well-being of people living with and at risk of poor mental health. There have been a lot of exciting gains over the past 30 years, to be sure, but especially in the last 15 years. Policy developments. The World Health Assembly, for the first time, signed a set of targets to be achieved for mental health by 2030. So we have global frameworks that did not previously exist. More countries have national mental health policies, which means that more countries can take coordinated action within countries to move the agenda forward. There's much more investment in mental health research, particularly in low and middle income countries, and more diverse populations globally engage in a range of science. And as for innovation, there are many innovations, but I'll mention two. The introduction of digital technologies for use in mental health, both as diagnostic tools to better understand phenotypes, as well as methods to extend care. And then innovation that's happened far from technology is expanding the evidence for task shifting, expanding the evidence to say that we can use a variety of people to deliver mental health services in settings around the world, and they can deliver effective care and can do that with quality. What needs remain? We need the translation of research advances into sustainable real-world action, investment in promotion of mental health and prevention of mental disorders. We need to scale up services as an integral part of universal health coverage, and we need to see the full integration into the global response of other health priorities: maternal health, child health, HIV and AIDS and other pandemic responses, climate health. And this is where we can have impact at the intersections. So for anyone that needs to leave early, those are the main messages. And now we'll dive into more of a story. So 1994, the big year, I was at Columbia University in the New York State Psychiatric Institute as a resident. I had done my undergrad training at Purdue University, gone to Cornell in New York City for medical school, and done a one-year fellowship at Rockefeller University studying obesity, and realized that I am not a basic scientist. So I'm going to stay away from that. And I really like people, and I really like social science research. So went to Columbia, knowing that I wanted to do global mental health, and began to look for mentors who could help me along the way. And I'll tell you about some of those people. Did my residency there, did my fellowship there. At the end of residency, started public health school. Myrna Weissman was one of my mentors, and she said, if you want to do anything international, you need to get an MPH. So I did. Had a wonderful opportunity through the Fogarty International Center, funded by Fogarty at the University of the Witwatersrand in Johannesburg. Had a one-year fellowship at Harvard Medical School as part of my K Award in the Department of Social Medicine, but was on faculty at Columbia for quite a long time. I was recruited to the National Institute of Mental Health in 2009, stayed there. I always say I came 6 months after Obama and left 6 months after Obama, and then moved to Seattle for the University of Washington, and then here to the Bloomberg School of Public Health. So in 1994, the contemporary conversations in this field, which was not called global mental health, but cross-cultural psychiatry, were really about research and thinking from the late 80s that brought efforts to bridge the anthropological and the epidemiological trends, these traditions that shaped cultural psychiatry. And cultural psychiatry really is the precursor to global mental health, cultural psychiatry and psychiatric epidemiology. So this bridging created this new cross-cultural psychiatry that acknowledged the universal features of mental disorders, that there are some things we recognize everywhere, together with the contribution of contextual and cultural influences that might affect the expression or people's explanations for illness. In the early 90s, several milestones paved the way for the development of our current field. One was the 1990 Caracas Declaration, which set forth principles to transition mental health care from hospital-based settings into community mental health services in Latin America and the Caribbean. Also in 1990, the Council on Health Research and Development published a report, Health Research, the Essential Link to Equity and Development, which recommended accelerated action in health research, international partnerships to mobilize capacity, investment in research in lower income countries, and monitoring progress to see how this can actually reduce inequities. In 1993, the Global Burden of Disease study put mental health on the map when findings suggested the significant contribution of neuropsychiatric disorders to global disease burden. And in 95, the book World Mental Health described drivers of poor mental health in low-income countries, really shining a light on the disparities between low-income and high-income countries. And you can see an image of many of the other milestones that occurred over the subsequent 20 years, and I'll talk about some of those as we go along. But my entry, as I mentioned, I was a resident and looking for mentorship around two specific areas of interest. I wanted to understand broader frameworks for understanding mental health and mental disorder. And I really wanted to understand, how do you develop culturally congruent approaches to care? And part of this grew from my own interest and concerns about the mental health and mental health care of African Americans in the United States, who I felt needed a broader framework to navigate these systems. I met Ezra Susser, who enthusiastically invited me to join him. And the work that began in residency aligned with three themes. First, understanding the expression and course of mental illness in different cultural contexts. We began to work in India, exploring the expression and course of acute psychosis, really trying to better understand this finding that people in less developed countries had much better courses of healing, I would say, for psychotic disorders. So we were trying to understand that. The second area was around examining systems of community-based care for severe mental illness. And we went to Argentina and worked with colleagues there around using local resources for the integration of mental health care and primary care for improved treatment coverage of severe mental illness in the province of Neuquén in Argentina. And some years later, in 2003, I was working with the Pan American Health Organization to evaluate the mental health reforms of the neighboring province of Rio Negro, which was also trying to implement, or had implemented and was trying to sustain the implementation of pretty innovative ways of doing community mental health. The third theme was about reducing vulnerability in the community, and specifically reducing HIV risk for people with severe mental illnesses. That work actually began with a trip to South Africa for me in 1995, and later grew into projects I'll talk about. And in New York City, I worked with women with severe mental illness and HIV prevention, and later, after treatment became available, began to focus really on how do we integrate mental health services when people are living with HIV and need access to care. In fact, after treatment became available, I was part of the founding secretariat of the Mother to Child Transmission Plus initiative at the Mailman School of Public Health. And this began to provide HIV care to women and their families and households in sub-Saharan Africa. And I began to work with multidisciplinary teams to build capacity around psychosocial support and depression in the context of HIV. This initiative later became ICAP at Columbia, which is now a leading global health research and implementation center. And we'll come back to that as well. But I want to give you a little bit of the context for integrating mental health and HIV services, because it was through a deeper dive in this work that I came to think about global mental health in particular ways, and working at the integration of these different kinds of services influenced a lot of the way that I certainly thought about how we keep mental health on the agenda, how we expand access to care for different people. So a quick primer. In the United States, we have a general population prevalence of HIV around 0.4%. People with severe mental illness in the United States, when I say severe mental illness, I'm talking about chronic psychoses like schizophrenia, chronic bipolar disorder, conditions like this, have a prevalence of around 2 to 6%. This is a 5 to 15-fold difference. And in the early 90s in New York City, Ezra Susser and colleagues drew attention to the high prevalence of HIV among men living in New York City shelters, most of whom had serious mental illnesses and concurrent substance use disorders. We learned over the years, of course, that this pattern of elevated risk for people with serious mental illness happened in many countries. And essentially, when you look at these data from North America, Europe, Africa, Central and South America, and Asia, I think a takeaway is that in countries that do not have a generalized epidemic, you see a much higher prevalence of HIV infection in this population. And in countries where there is a generalized epidemic and a high prevalence, you see an equally high prevalence, if not higher, among people living with serious mental illnesses. So the next step in this work for me in New York City at the time was to really understand what were the experiences of women. My mentor was working with men, no one was doing the work with women. I wanted to understand those experiences, listen to what people's lives were actually doing for them, what they were living, so we could develop some interventions. So we knew and we know now that vulnerability to HIV acquisition among women with mental health conditions is affected by or increased by stigma and discrimination, by social vulnerabilities associated with long-term socioeconomic disadvantage in many cases, sexual and drug use behaviors that increase vulnerability, coercive sexual encounters, and psychiatric symptoms sometimes. So I began to interview women. These were predominantly women of color, collecting narrative data about women's lives, their understanding of their illness, and its influence on their sexual relationships. We used this information to develop and test a behavioral intervention for delivery in clinical and residential settings, really emphasizing how can women have more control over HIV prevention in their lives. And we worked to understand the intersection of identities that were stigmatized and the influence of stigma and discrimination on HIV risk. And this is what one of our participants said in talking about her relationship. She said, sometimes I'm kind of blind to the fact that it's not going to work out because you want it to work out so bad. It takes sometimes a while to see because you don't want to be lonely without a companion. And then when you're having an argument, he wonders why you're acting like that. What's wrong with you? And it's hard for you to explain because you don't understand. You're in the state of symptoms and you wish you could get out of it and you don't know how. And there's no way out. You have to go back to the doctor, pray, do something. So we heard many stories from women, and their stories were often intertwined with immigration experiences. Most had lived in poverty with limited experiences for education. They had worked in factories or private homes as domestic workers. Others with greater means had operated small businesses. Many of them expressed dismay at life in a big city like New York, where there was little social connectedness. But our data found that women internalized and resisted the stigma attached to mental illness in their communities by aligning themselves with identities that bestowed dignity and respect, regardless of how well they were able to live up to those images. We also found that immigrant status, in the case of our sample, which is largely Latina, being poor, espousing the local community's ideas about relationships, race, color, could add to the difficulty of managing relationships in the setting of a mental illness. And finally, women really showed us that their risk occurred through a variety of conditions and situations. It occurred when they were in monogamous relationships with men who were sometimes unfaithful, when they experienced sexual abuse, when their loneliness or desire for relationships combined with their symptoms prevented them from leaving a risky situation, or when symptoms impaired their judgment, or when they engaged in unprotected intercourse without knowledge of a partner's serostatus. So these were lessons from New York. And In the mid-90s, we began to work in South Africa. Columbia we had a relationship with South Africa through a Fogarty grant. So the School of Public Health, the Department of Epidemiology was bringing people to study epidemiology in New York City. My first visit to South Africa was in 1995. And over the subsequent years, we rapidly established a collaboration with the Directorate of Mental Health. Now, they had just entered a new democracy, wanted to do mental health reform, and the first place was to start to deinstitutionalize. At the same time, there was a rising HIV epidemic, and we shared our experience in the United States that this is a potentially quite vulnerable population, and we began to collaborate around ways of really instituting HIV prevention in communities and in psychiatric hospitals. We studied the prevalence in psychiatric hospitals, showing that it was equally as high as in the community, and often sometimes higher among women who were hospitalized, and began to work to design prevention training for staff in collaboration with the directorate, and served on their mental health task team for HIV prevention. And I think this experience showed me that it's really important to work with people who are going to be able to sustain the work. If your funding abates, your own federal funding abates, then they also have ways of sustaining work. And partnering with government became one of the things that I felt like was very important to ensure that health research can be translated into ongoing practice. So the work in New York and South Africa involved working with providers in institutional and community settings. Watch the time. And we identified some of the same vulnerabilities in both countries. In overly restrictive policies on sexual activity that intended to protect women often had the opposite effect of actually keeping people from taking action around prevention when risky activities were happening. We found that new policies, however, can be developed to abate these kinds of risks. We also found that cultural norms, both professional and social, for the provider could deter discussions of sex and often medicalize sexual behavior, again, making it often unlikely that people would talk about HIV prevention. But nevertheless, providers in both countries really accepted the responsibility for HIV prevention and education among the people that they cared for. So conspicuous in our work in South Africa in the early 2000s was the general lack of access to HIV care and treatment and the high mortality among patients and staff. This began to shift with the advent of global funding for HIV care, and my work also shifted to support the development of multidisciplinary HIV care and treatment teams to address psychosocial support and mental health needs. Although HIV care and treatment resources were growing, mental health resources were not. In fact, mental health systems in some countries were losing their staff to better resource HIV programs. If you were a social worker, you could get a job as an HIV counselor and perhaps make more money. So many of the countries in which this work was growing had extremely limited mental health resources. First-line HIV providers lamented that they had insufficient knowledge and training to help people manage responding to a positive HIV test, adapting to living with this chronic and fatal condition. But this also provided a potential opportunity in HIV services. And we asked this question: can mental health interventions be provided in settings that are already desperately short of mental health resources? In 2005, when some of this work was happening in Africa, where we were working, there were very few mental health specialists. There were one psychiatrist for 2.5 million population on average, one psychiatric nurse for every 500,000, one psychologist for every 2 million. And so the question began, how can we begin to utilize the resources that are going to HIV to meet mental health needs of people living with HIV? And that's something that we continue to ask and continue to work on. But I'll briefly talk about our experience beginning to integrate mental health and HIV through work with ICAP in Rwanda. On a visit in 2007 to talk about mental health and HIV services, my colleagues encouraged me to visit the psychiatric hospital that's in Dera. The hospital was directed by Father Charles Nkubili, a priest with the Brothers of Charity. This was the organization that supported the hospital. When I shared with him my interest in HIV and mental health, he shared with me a proposal that he'd already developed about how can we integrate these services in psychiatric hospitals in Rwanda. He estimated that the prevalence was high among people receiving care at Indera, but when people were admitted to the hospital, they lost access to their services. And this fragmentation of mental health services is true around the world, and the separation of mental health care from other forms of healthcare. So this conversation launched a collaboration between Indera, ICAP Rwanda, Track Plus, which was the Ministry of Health's HIV services, the National Mental Health Program, and Colombia. This was an incredibly motivated group, and within 2 years, we were able to build HIV services at Indera, complete with laboratory systems and the delivery of ART to people admitted to the hospital. The group went on to expand this to district hospitals, bringing antiretroviral therapy nurses and psychiatric nurses together through case conferences. But the sentiment was that patients are people who want to live, and you can't let them die. You can't abandon them. People arrive and they say they've forgotten their medications, and then they risk having disrupted treatment. So as all of this was happening, I got a phone call one day inviting me to apply for a job at NIMH. And I was recruited to the National Institute of Mental Health to lead the Office for Special Populations. The Office for Special Populations was responsible for women's mental health research and research policy, mental health disparities research in the United States, sex and gender minority research, scientific workforce diversity. We had a separate office for rural mental health research, which I also took on the leadership of, minority mental health, and over the year after I arrived, we merged into this Office for Special Populations, Global Mental Health, and we renamed it the Office for Research on Disparities and Global Mental Health, and added to our portfolio research capacity building in low and middle income countries and global mental health. So when I got to NIH in 2009, this was a really global health friendly time. The Obama administration had a White House Global Health Initiative with a $63 million planned investment. Francis Collins, the new NIH director, had named global health as one of his priorities. All of the institutes were already supporting international research and research training, but most of that was in high-income countries. And there was actually little equity focus. And as I say, the majority of investment was going to Canada, Europe, Australia, other high-income countries. So it was really exciting time and a real opportunity for all of the institutes, including NIMH. So among the many areas for which my team was responsible, global mental health presented a vacuum. There wasn't much of a portfolio. The global work tended to be in our HIV portfolio. So we launched our activities with 5 guiding principles. First, to generate evidence to solve tough problems with the best research. And we believe that the best research happens when you get the best thinkers from wherever they may reside in the world. We wanted to focus on equity, and that meant addressing and recognizing the tremendous treatment gap experienced within and between countries, including low and middle income countries, and the urgent need for solutions that were rooted in local evidence. We wanted to integrate mental health into global platforms of care, recognizing that curbing the HIV epidemic, improving outcomes for mothers and children could not be truly accomplished without attention to the mental health needs of these individuals. And we wanted to anticipate global public health threats. In some places, this meant thinking about the high and growing rates of suicide. In others, the non-communicable disease epidemic. And finally, our 5th principle was to build research capacity, starting where the needs were greatest in low and middle income countries. And this would actually create the ability for global collaborations and collaborative research to solve global mental health challenges. So to begin to generate evidence, we decided to embark on priority setting. What is important? Where do you start when you want to build a portfolio? So we launched the Grand Challenges in Global Mental Health, which was an initiative meant to set priorities for research over the next 10 years that would make an impact on the lives of people living with mental, neurological, and substance use disorders. We built collaborations with other funding agencies to accomplish this. NIH joined the Global Alliance for Chronic Disease in 2009, and this group had 2 years before published the Grand Challenges in Chronic Non-Communicable Diseases, and they had not included mental health, and we were upset about that. So we decided we'll do our own. But we worked with the GACD. They added mental health to the agenda, and in collaboration with them, NIMH led the Grand Challenges in Global Mental Health. We created an executive board of funders with the explicit intent to build funding in this space. We worked with a broad group of participants to complete a Delphi study that yielded 6 goals and 40 challenges. You can see what these 6 goals are: identifying root causes, risk and protective factors, advancing prevention and the implementation of early interventions, improving treatments and expanding access to care, raising awareness of the global burden of mental health conditions, building human resource capacity, and transforming health system and policy responses. This is what some of the challenges looked like. But of the top 5 challenges overall, 5 of them were related to improving treatment and expanding access to care. So integrating screening and core packages into routine primary care, reducing the cost and improving the supply of medications, providing effective and affordable community-based care and rehabilitation, themes we had been working on and that the field had been addressing for decades, or trying to address, and improving children's access to evidence-based care by trained health providers, particularly in low and middle income countries. Excitingly, when we published the Grand Challenges, a member of our executive board, Peter Singer of Grand Challenges Canada, announced their first investment in mental health with a $20 million call for proposals to address Goal C, improving treatment and expanding access to care. Other funders expanded their investments in global mental health, as did the National Institute of Mental Health. And some years later, the Global Alliance for Chronic Disease, also building on the Grand Challenges, launched a multi-country initiative with its partners, including NIH, yielding 34 additional projects across many countries. So we had the Grand Challenges, we had a set of priorities, and we began to think creatively about how and what we should do to expand care. And we engaged people in the community. We brought together people in the community for our first meeting in 2010 to find out, how can research help you do your work if you're in a Ministry of Health, if you're an NGO, if you're a researcher studying mental health services? In this case, we were talking specifically about low resource settings. Or if you are a service user, how can it help you? And from that meeting, we found that people felt that research, what was important was research that could address the need for human resources. And we developed an initiative to build the evidence base for task shifting, to create research capacity for networks of people, so not just one institution, but building research capacity for a region. And we wanted the research to be informed by the voices of people with lived experience and people who would actually be able to use the findings of the research. So we required that our investigators included policymakers, included people with a clinical perspective in the work, so that it had this kind of relevance. And we wanted this initiative to also generate research questions across the network so that they could learn from a diversity of contexts in health systems. And we called these collaborative hubs. Over the course of time, we developed a progression of collaborative hubs focused on task shifting, focused on implementation science, and in collaboration with the Global Alliance of Chronic Diseases, covering quite a number of geographies. So that was one initiative that we felt had considerable impact, both on building capacity and linking mental health outcomes to ongoing policy. A lot of our work was focused on low and middle income countries in the office, but in 2015, when the United States chaired the Arctic Council, we had the opportunity to lead the US government's initiative to highlight the tremendous disparities in suicide deaths among Arctic indigenous people. And in that work, we led a priority setting exercise to help determine what kinds of interventions are most important for reducing suicide, and what should those interventions entail. On the heels of this, we took our collaborative hubs initiative, that idea, and thought, how can we apply that at home? And we developed a set of collaborative research hubs on suicide prevention for American Indian and Alaska Native communities. And this is work that is ongoing by many of our colleagues here at the Bloomberg School of Public Health, who found that this hub mechanism enabled them to take advantage of longstanding community-based participatory research and governance processes to inform and design evaluation. It enabled them to use multi-level frameworks for identifying risk and protective factors. It enabled them to utilize task shifting and systems of care tailored to low resource settings, and to use strength-based approach. And meanwhile, we kept pushing the importance of integrating care. And this was an example of a PLOS medicine series that we led on integrating mental health that was accompanied by a call for proposals to say, well, let's start to build the evidence. Let's see what happens when you integrate mental health into HIV care, into cardiovascular disease care, into maternal child and health care. And our final emphasis was on building research capacity. And that really focused on what are the gaps in these pathways to independence for underrepresented groups in the US, for US trainees interested in global mental health, and for trainees from lower middle income countries who simply wanted to get involved in mental health research. What are those gaps? And we began to collaborate with other institutes, including Fogarty, to try and plug in those gaps. I think one of the biggest challenges for research in the lower income countries is what we see in less research intensive universities here in the United States, the competing demands for people's time and struggling to figure out how do you carve out the time to support a research agenda. And in the midst of all of this, we were able to build a global research community through convening people regularly. So by 2015, this global mental health research community had become also a powerful voice for advocacy in the lead up to the Sustainable Development Goals to ensure that mental health was included in the Sustainable Development Goals. And efforts like Fundamental SDG worked to provide ideas for indicators and targets, and were successful in seeing mental health integrated. In 2016, we thought, we've been spending a lot of time working with ministries of health, but we haven't worked with ministries of finance, and they're the ones that hold the purse strings for funding of care. And so with the World Health Organization, we collaborated with the World Bank to host a meeting in 2016 that said, let's get the evidence for depression to the World Bank so that people can see what's the return on investment with a basic package of care for depression and anxiety in low resource settings, middle income, high resource, and can we make these investments? So that was a pretty major milestone. So moving on from NIMH, I went to the University of Washington, where they were wanting to scale up their global mental health activities. And I was actually quite interested after being for 8 years at that 50,000 foot level and kind of getting back into doing the work, right, and seeing what that was like. So went to lead the global mental health initiative there. And we started out with a strategy for action, really focusing on how do we understand the mental health environment in different settings, how do we build a workforce, and how do we work to elevate mental health on the global and local agenda. For the first one, we worked with the World Health Organization. We began to work with them on the Special Initiative for Mental Health, which has a goal of scaling up mental health services in 12 countries, 9 are currently active, to care for an additional 100 million more people. So we worked with WHO to provide the analyses, the situational analyses for 9 countries in the special initiative, and to work with some to develop evaluation frameworks, to support initiatives to help policymakers understand how best to mobilize around mental health. In understanding the gaps and opportunities, in my own work, which was growing around adolescent health, we saw an opportunity to collaborate across the university with folks around adolescent mental health in cities, and also working with a nonprofit organization called Cities Rise. We led research to understand if we want to actually intervene to support mental health, can cities be the source of that work? Can cities really be the environment or the actors to support the mental health of young people? In work that is ongoing, we launched a priority setting exercise, making cities mental health friendly for adolescents and young adults, to identify how cities could work both at the individual level for young people, supporting interpersonal relationships. How could communities come around young people, organizations, and policies? And as I said, this work is ongoing. Similarly, in understanding these gaps and opportunities, kind of coming back to this idea of how do people in different contexts address mental health services? What is congruent? What's culturally congruent in a particular setting? In many contexts, in many settings in West Africa, and this work is in Ghana specifically, the place where people get care for mental health is not in the health system. The majority of people actually receive their care in prayer camps or more faith-based settings for mental health. So we began to work with prayer camps and with colleagues at the University of Ghana to say, is there a way to increase the quality of the care that happens in prayer camps to ensure that people do not use practices that are abusive, and to do that by teaching healers to deliver psychosocial interventions through phones? So creating an app that coaches a healer on what's the best way to deliver a low-intensity intervention for people who are experiencing hallucinations, for people who are agitated. How can we do this? And this is also work that is continuing today in a trial of multiple prayer camps in Ghana. Our second goal was around building the workforce, and this work happened in collaboration with the World Health Organization, which has been trying to understand, as we build this workforce through task shifting, how do we ensure the quality of care that lay health workers develop? And can we improve quality by teaching people competencies, core competencies for psychological interventions? And what is that like? So we began to do this kind of work in Kenya, working in a neighborhood in Nairobi, building on long-standing relationships with partners in Western Kenya to train lay health workers and psychologists to deliver a brief trauma-focused intervention to young people. What happened during COVID, we had to adapt all of this work to phone-based intervention, but we saw good results, even in this brief pilot, using an evidence-based treatment. And that led to a current set of research that I'm involved in, integrating a transdiagnostic psychological intervention in the care for adolescents with HIV in Kenya. So again, this is that idea of saying, we need to bring mental health care into HIV. Who are the providers in an HIV setting that can deliver this? And what do we need to learn about those contexts to ensure that the care happens effectively and competently? Finally, with respect to elevating mental health on the global and local agenda, advocacy was a key part of work that we did around this theme of integration, working with UNAIDS to develop the first, their first guide for how do we integrate care at their program coordinating board meeting in 2018, later led to a great interest of countries supporting this work to say, this is important, and we actually need guidance to know how should we integrate HIV into mental health. And I worked with UNAIDS to develop the guidance that we've been using. And now, as UNAIDS is developing new targets for 2026 to 2031, I think really being able to specify how should mental health be a part of this is an important conversation. I'm going to go quickly because I realize we're going to run out of time if I don't move ahead. But a lot of this work around integration happened not just in research, but also through implementation. I had the opportunity at University of Washington to lead ITEC, which is also another large global health implementing center that scales up HIV care and treatment programs. And working around the world, ITEC has the opportunity to bring mental health into other health systems through its integration work. And this is one example of that work in Mozambique, where our colleagues were using the Common Elements treatment approach, which was developed here at Hopkins and with colleagues at UW in Mozambique, and really showed that this treatment delivered by lay counselors to people living with HIV significantly reduced symptoms of depression, significantly reduced suicidal ideation. And with that, PEPFAR made the decision that this should be scaled up across all provinces in the country. And so ITEC continues to work to support this effort to scale up mental health care. We combine this work, this implementation work, with applying for and getting funding for a research center focused on integrating mental health and HIV, with the goal of saying, let's take what we can learn from practice, both globally and in the Pacific Northwest, and see how we generate good research questions. And we did that, we began to do that with developing a learning network with our ITEC sites, where different countries that were working on mental health could come together and learn from each other about what's challenging, how are you ensuring that you get this approved at the Ministry of Health, what's happening when you actually try to implement a psychological therapy, what are the challenges and how can we work these out? So I think this kind of practice-based learning has great potential to help us generate good research questions. And over the years, both at UW, and this continues now with colleagues here at Hopkins who have also moved from University of Washington, we had the experience to work with the African Cohort Study, which follows people living in Nigeria, Uganda, Kenya, and Tanzania to understand the course of HIV. And these are people that are in care. And I've been leading a group that's focusing on asking questions about mental and behavioral health in this cohort study. And this work, I feel, is also data that can help to inform how and why we need to continue to push for integration of mental health care. In this study, we've shown that there is a relationship between exposure to depressive symptoms and mortality for people living with HIV, that in fact, every 25% increase in the days lived with depression was associated with a 69% increase in the risk of all-cause mortality. And this was consistent with a US study of around nearly 6,000 individuals living with HIV. The same cohort also showed us the relationship between perinatal depressive symptoms and viral non-suppression among women living with HIV. I think making the point that maternal depression is important to address in HIV, and we know that this increases the risk of poor adherence, poor child mental health outcomes, and of course, the mortality issues remain for this group too. At the end of one of our explicit goals at UW was to work with WHO and to formalize that by establishing a WHO collaborating center. And we were successful in doing that to solidify that opportunity to disseminate research findings. So, what does the future hold? Global is not the opposite of local. So Baltimore is a part of the globe, and what we do here, we should be doing in collaborations with our colleagues globally. Global mental health rests on equity. The work that we need to do is important for a diversity of ideas to solve problems, provides us with opportunities for mutual learning, for evidence generation in local contexts, for translation where relevant. And this increases our access to research, attention to social and structural factors, and attention to power. These are all important emphases for global mental health going forward. When we think about what's in the future, I think these are some of the areas that are important public mental health challenges in our country and our city, but also in other places around the world, where there's not necessarily as much focus. Drug overdose is obviously one of those. Urbanization as a major force for mental health and the needs of people living in cities. Youth mental health, cognition and aging, climate health, digital health. And I think we have an opportunity, as we said at the beginning, to really focus on mental health promotion. How do we sustain mental health and not only address disorder, but how do we actually promote mental health from a public health perspective? Finally, I want to say that there's a group that's coalescing to say that, we need to think about mental health as brain health. When we launched the Grand Challenges, we defined mental disorders as mental, neurological, and substance use because of their shared relationship to the brain. Well, others are also paying attention to this, and data from the Global Burden of Disease study would support that 43% of the global population is actually affected by 37 neurological conditions, which include things like autism, dementias, ADHD, which kind of fall between our various fields. But again, this is another opportunity to think about how do these intersect and how might these communities work together. So thank you. We have a few minutes. I want to just acknowledge many mentors, colleagues, and collaborators over the years and supporters. Say thank you to all of them and those of you who are sitting in this audience or online. And I want to acknowledge my family and my friends. This is my big brother and my husband. So thank you.
Well, thanks so much, Pamela. We do have some time for some questions. And if anybody online has a question, is that a clap hand or is a raised hand? That's a clap hand. Yeah. But we'd love to entertain any questions for Pamela. Yes, go ahead.
You mentioned that people with mental illness in low-income countries have to fare better than those in high-income countries.
That's a finding from some of the early WHO studies, which people were, I think, quite taken by. And that's actually become a bit controversial over the years. So there are some camps that would say, yes, that's true. That's very good evidence. And others would say, there's probably other explanations for that finding. And that, in fact, may not be true. So there are a number of new studies ongoing right now to really try and understand in this day and age, what do those outcomes look like in a diverse set of countries? But please, you were going to say something else about that.
Yeah. So it sounds very paradoxical. So yeah, I wanted to ask your interpretation of that phenomenon.
Yeah, I think when the finding first came, people felt like it was because part of it had to do with the flexibility of roles, right? That if you're in New York City and you have a psychotic disorder, there are very few things for you to do to sustain your livelihood, to be able to, you're more likely to be isolated from family, whereas in countries that are more communal, where you have more family support, where there may be maybe more rural settings, there are more things that people can actually do to both sustain themselves and to be integrated into community with these kinds of conditions. So that was a lot of the thinking, but I have colleagues that would argue about that. Sure.
I see we have a question online, but I can't read who it is. Great. Oh, great. Go ahead.
Great job, Pamela. And it's really wonderful that you're able to balance all these vast experiences and to the benefit of our Department of Mental Health, working with WHO and domestic and international and NIH and ministries of health. So I have a question that relates to integration of care with HIV delivery system. You know, we sequentially have added family planning and other infectious diseases and mental health care, and now we're talking about NCDs and cancer and geriatrics. And as someone I think I went to WITS in 1995 or 96 as well. It raises the concern. I think most of the data suggests that things tend to get better. You add additional services and outcomes don't seem to go down, but things to get better. I just want to know if you think there's other lessons learned from integration of mental health care, or if you're concerned about a breaking point or a tipping point where you just keep adding things to the HIV care delivery system and maybe it overwhelms it.
That's a great question. And I think it's a question a lot of people have been asking. You know, I don't think we've added enough mental health to the HIV delivery system to overcome it or overwhelm it. But I think what we've learned in general in this idea of expanding mental health services is that we also have to not be afraid to say, you know what, everything can't be done by the same provider. In fact, you actually do have to invest in people that can do this work, right? I think a lot of colleagues in South Africa who've been looking at this question and, can we make sure that community health workers do it? Who in primary care can do this? Have really found that creating other cadres is often necessary. So I think the answer to that question depends on the context, but I also feel like we shouldn't be afraid to say, you know what, with whatever we're trying to integrate, it's going to cost more. Integration does cost more, generally a little bit more, but to do things well, we may need to add other services. I think the challenge in mental health care is that, as I mentioned, a lot of mental health systems, the mental health systems are not as wealthy as the HIV care system, right? And so I think those conversations are happening now as UNAIDS thinks about integration going forward. What's the level of integration? Do we need to rethink some of these types of, do we need more relationships with the other areas of the healthcare system? Should they have more collaboration with HIV care systems, right? So that's the answer.
Gee, thanks a lot.
Yeah, go ahead.
Thank you for hosting this. I had a quick question. You mentioned about the financial side of approaching mental health. As someone who just graduated from the MPH MBA program, I noticed a difference between the School of Public Health and the Career Business School when mental health is talked about. With your experience, and what advice or recommendation would you give to people that are going out in the world and trying to integrate the financial side, the business side, along with the mental health side, whether it's sponsoring programs or funding programs? And if you received any pushback while you were going through these talks and ongoing talks that you've been doing. Thank you.
You know, that's an interesting question. I'll answer the last question first. I've definitely sat in rooms where people have said to me, children are dying. We can't worry about mental health, right? We can't, you have to prioritize. You can't do everything. And I think our response is that, yes, we know that children are, and we don't want children to die. No one wants, we want to do all the things that we can do in public health to improve population health outcomes. But I think the question has been, you can do that, and you still have to have a mom that can take care of the child, right? You still have to be able to support people's overall health to achieve those health outcomes. And so I think in all of our programs, we have to remember that human beings have multiple problems. And so keeping programs vertical, feeling that we can exclude the other health needs of people doesn't usually result in the best outcomes for their care. And I want to know, yes, please advocate for financing for mental health in the private sector. That's the other.
We have a question online from Sydney.
Oh, thank you. Thank you very much, Pam, for the insightful talk. My name is Sydney, and I'm joining all the way from Cape Town, South Africa. So happy
welcome.
to see the work that you have been doing in South Africa. But I'm originally from Zimbabwe. You mentioned something about the utility of task shifting, and I'm fortunate enough to come from a country, Zimbabwe, where task shifting in mental health has been used extensively. What are some of the challenges that you've noticed with this task shifting approach in your work across different African countries?
Well, you're right that I think you and colleagues, our colleague Dixon Chibanda and all the Friendship Bench group, they have such vast experience in real world implementation of task shifting in Zimbabwe, and that model being used in so many other countries. I think the bottom line is that it's really hard to actually it's hard to move things from a nice effectiveness study to a real world health system. It's really hard because health systems are complicated. But we have to try, and we have to keep trying, and we have to learn from all of those efforts. So I think what we're learning is that it's complicated to implement large efforts like task shifting in real world settings, but people are learning what can make that easier, right? Supporting people, ensuring that people have good supervision, ensuring that there's ongoing coaching, ensuring that there's ongoing financing, ensuring that people can actually earn money from providing these health services. There are a lot of things that can help to make that better, but often those are in jeopardy or at least unstable.
Great. I think we have time for 2 more questions. There's one here.
I actually had my hand up.
Go ahead.
Okay. Hi, thank you so much for your insightful session. So my name is Sonti Bacharapon, and I'm just graduated from MPH program here in May. So I'm really interested about innovation thing, and I see that you mentioned about mHealth and initiative in Africa. So I wonder that apart from that, are there any other ongoing innovation project that try to address mental health issue, and how can we ensure about the equity to access to that kind of innovation? Because when we talk about that, sometimes there are barriers for people to access that. So I'm quite curious about that thing, and how can we promote equity on that?
So there are a lot of efforts around using technology. I think that's, and a lot of that expanded during COVID, right? Using technology to extend access to care, whether that's as basic as cell phones for telehealth to real complicated digital platforms for expanding care. So I think that's an area that's growing. How do you get involved in that? Is that what you're asking?
Yeah, I'm like I wonder about other initiative apart from mHealth, because now we talk about like AI and other like kind of innovation. So I wonder that if there are other opportunities that we can to promote that kind of address.
Yeah, I think the digital AI, I think that's going to be a continuing field where we keep learning and where we have more opportunities. I don't think we have time to go into all of it now, but the answer is, yeah, I think this is a huge new frontier for us, for mental health and for health, right?
And we do have 2 more questions online. Bafor, I know you've had your hand up. So could you ask your question?
Thank you. I asked the question, are there any particular investments and measures to ensure that lessons learned from the global south actually move up to the global north to really make it global, as the name suggests, because usually there is a preponderance of knowledge from the global north to the global south, but we don't see the counterflow. So that's my question.
That's a great question. And I think that's the reason why we do this work. The reason that we want to make sure that countries have adequate funding to do this work is for that very reason, right? That we're learning from everyone, that people are able to ask the questions that they see are important in their context. But we were just talking about Zimbabwe, and I think Zimbabwe is a great example of an innovation that has left Zimbabwe, has gone to other African countries, has gone to Europe, has come to North America, has come to the United States specifically, and people are learning from that work. How do you implement the Friendship Bench, a problem-solving therapy intervention that was adapted to work in Zimbabwe, but now is coming back to many other parts of the world because of it's a low barrier form of care. It's can be delivered by non-specialists. It seems to be feasible and acceptable to people. So I think that's one really large example that's quite that's being explored extensively around the world.
All right, thank you.
Sure.
And Bill Eaton, we'll give you the last question here.
Can you hear me?
Yes.
Yep.
Okay. Well, my question was very similar to the last one, and that is, how much can we learn? Not that we teach in the global mental health, that we're so much smarter and so much more advanced. But can we learn from visiting other countries, because they've been dealing with mental illness for thousands of years, just like us, and sometimes they have ways of thinking about it and doing things that are better than ours, and we can learn from them. So, for example, have schizophrenia, it's a lot better if you live in Mauritius than if you live in New York City, because the culture is better for it. So I just think there should be an effort to try to learn from the different cultures and improve our own mental health work.
Bill, I think you've put the hammer on the head. You've nailed it. Bill, that's exactly what this whole endeavor is about. It's really about how do we learn from each other? How do we make sure that everybody has the resources to be able to promote, propagate what they're doing? How do people have the resources to be able to build an evidence base? How can you share that evidence base with us? How can we share evidence base with you? How can we really have an approach that involves mutuality, right? It's mutual learning. It's recognizing that we can, that we need to receive knowledge from many different corners of the world. Like, to me, that's the whole point of global health, is that we take advantage of a lot of brains and experience that are being brought to bear on challenging problems, and global mental health should be no different.
And I think, Bill, you've just summarized Pamela's past and future work in the area of global mental health. Thank you, Pamela, for a wonderful Dean's lecture. Got us all thinking about mental health in a very important way. And I would love to invite everybody here to join us by the Wall of Wonder for a reception, and we can continue this conversation. Thank you.
Thank you so much.